Dear friends, in this video, I'm going to talk about what is new in sepsis. It is known to all of us that sepsis kills nearly 11 millions of people every year worldwide. But we often forget that it represents 20% of all global deaths, and that is a huge number going by statistically speaking. Now, what is the reason that sepsis therapy often fails? The first cause which has been linked to this therapeutic failure is significant delays in initiating the treatment. Now, not necessarily this delay is entirely because of delayed diagnosis, etc. It is sometimes because of the logistics delay, because of the availability of facilities, or the transport of the patients from a lower center to a higher center. So these are the reasons for which the therapy gets delayed during initiation. The second is the precise mechanisms of organ dysfunction in sepsis is ill understood. When one organ will develop dysfunction consequent upon sepsis, and what will be its rate of progression, there is considerable variation between individuals, and it is difficult very often to understand or to predict the rate at which the dysfunction will progress. Third is that the immune response in humans, particularly in patients with sepsis, is more complex and variable. Although we know that this is in the form of immune activation, the immune responses vary from immune activation to immune paralysis. And the anti-inflammatory agents work during the immune activation stage, and during immune senescence and the immune paralysis phase, the other drugs to activate the immunity is worse. But this is only a very simple bird's overview of a very complex phenomenon. And in order to do that, one needs to understand the immune response in a much bigger way, at length, to understand the nitty-gritties of immune response in sepsis, so that effective therapy can be instituted. Now, this is one of the limitations and the reasons why sepsis therapy often fails. Next is that the type and nature of pathogen can significantly influence the immune response. The kind of response you can see after tropical infections in dengue, in scrub typhus, or the progression of this immune response, which leads to HLH or the macrophage activation, that also varies depending upon the nature of the pathogen. And also because site-specific immune response adds complexity. If the organ hit is the lungs, or versus if the organ hit is the liver or the kidneys, there will be variation in the expression of this immune response, and therefore the therapy will vary. So these are the broad reasons why sepsis therapy has often failed. And in response to these challenges, to find new therapies, to make new therapies work, the branch of medicine which is gaining traction and in the popularity of which is increasing is precision medicine. So if we have to practice precision medicine, what how would we practice? Or if you have to ask a question that what are the strategies to enrich treatment sensitive subpopulation of patients with sepsis? Now, how can we do that? Or even the question may arise that is this precision medicine same as personalized medicine? Well, the reply would be that precision medicine and personalized medicine are not identical things. They are often used interchangeably, but they're not identical. Individual medicine has two components. One is the stratified medicine, and the second is the precision medicine. In stratified medicine, if you want to practice personalized medicine, we have to practice both the arms. So in stratified medicine, where we put on clinical assessment and scores, go for the standard cultures, use the plasma biomarkers, go for immunophenotyping, determine the type and site of infection. And on that basis, we divide the patients into distinct groups. And after that, by precision medicine, we further segregate them through the genomics, transcriptomics, proteomics, metabolomics, etc. And also on the basis of the medical history and patient-defined goals, that as to what would be the target of therapy into further subgroups. For example, you can see in this figure that we have segregated initially the 8 patients into 3 groups of 3, 3, and 2 on the basis of stratification, on the basis of stratified medicine. And further, they have been divided into the therapy has been tailored to 3 drugs. And again, in the second drug, it has been in 2 different doses. And again, the doses can also vary with the time. So this is how we will have to practice. And there is a branch of theranostics which sees the monitoring the biomarker response to treatment. So the entire research on sepsis has been directed against this approach, personalized medicine approach. And therefore, as you can understand, that this is a complicated approach, not so easy to understand and fulfill, because it applies potent analytical platforms to assess this genome, transcriptome, proteome, and the metabolome of the patient. Now, based upon this analysis, a lot of results have also come up, and this was one result which was published in JAMA, which looked into the data of 63,858 patients in 3 observational studies and identified 4 novel sepsis phenotypes: alpha, beta, gamma, and delta, which differed with demographics, laboratory values, patterns of organ dysfunctions, and they were derived, validated, and shown to correlate with biomarkers and mortality. Of them, the alpha phenotype was the most common, and it included patients with the lowest requirement of vasopressor administration. The beta phenotype were next in number, beta and gamma, and beta phenotype were the older patients who had more chronic illnesses and renal dysfunction. The gamma phenotype had more inflammation and pulmonary dysfunction, and the delta phenotype had more liver dysfunction and septic shock. And there were consistent differences in the biomarker patterns on the basis of these 4 phenotypes. The cumulative 28-day mortality was lowest for the alpha phenotype and was maximum for the delta phenotype, and somewhere midway between those for beta and gamma. And it was also seen that in RCTs, the proportion of RCTs reporting benefit, harm, etc., in terms of outcome, changed the results from more than 33% benefit to more than 60% chance of harm. So there were big swings on the basis of these phenotypes as far as the outcome was concerned, or the mortality prediction was concerned. And therefore, certain subgroup of septic patients, certain subgroups were identified in the septic patients. And it has been going on since long. It is not that it has been going on for the past 20 years, that interventions, drugs have been used in specific subgroups and to see the mortality. For example, the anti-tumor necrosis factor, that is the IL-1 antagonist, they have, and the Fab monoclonal antibody, they have been used in specific subgroups, more than IL-6, more than 1,000. And the mortality's difference was not so significant. There was difference that it reduced the mortality, but it was not so much. There were further studies on this drug, afalimumab, and in patients with IL-6 more than 1,000, but they were trying to understand more precisely using more advanced biomarkers that how to further stratify this group and see in which patient this worked well. GM-CSF similarly has been found to be useful in reducing the time of mechanical ventilation when the monocytic HLA-DR was less than 1,000. IL-1 antireceptor antagonist has been used with features of HLH, and they have been found to reduce significantly the 28 mortality. It was 34% versus 64% for placebo. The trimodulin, which is a polyclonal immunoglobulin preparation, has been found to be particularly effective in reducing mortality, almost 1/3, in patients who had a very high CRP and low IgM. Now, these were all different types of studies. Some were prospective, some had exploratory, post hoc, etc. But these were the ways in which people tried to explore the subgroup of patients or identify which subgroups of patients can benefit from precision medicine. And because sepsis, ARDS, these are all heterogeneous. Heterogeneity of the host response is a major cause of difficulties in development of effective targeted therapies. Now, which biomarker holds the maximum promise? We know that we have already have few biomarkers which we have been using for sufficient time now. But among the newer ones, the mid-region fragment of proadrenomedulin, which is produced by vascular endothelium, directly reflects the plasma levels of adrenomedulin, which is a potent vasodilator agent with metabolic and immune modulating properties. Its levels increase in sepsis and there is high plasma clearance at day 5. And if there is high plasma clearance, it is associated with better outcomes. So this has been tried, and found to be useful for early identification of patients who have high risk of organ dysfunction. As I said, that identification of early identification of organ dysfunction can help into tailor therapies. So this study had found that this is a useful marker which performed better in the prediction of mortality, also other than organ dysfunction, of course, in compared to lactate, PCT, C-reactive protein, and the SOFA. So this is some useful marker which is on the anvil, and maybe in the coming days it can be very useful. The next important thing, new thing in sepsis is understanding the role of thymosin alpha as a therapeutic modality. Because thymosin alpha primarily causes augmentation of the T cell function, but it was seen that that's why it was used in oncology patients, because its actions extends beyond its effects on the T lymphocytes. It acts as an endogenous regulator of both innate and adaptive immune response. And you can see these are the various mechanisms which have been found to be true for thymosin alpha, the increases and decreases of CD8 4 to CD8 ratio versus IL-8 1 beta and TNF alpha, etc. And this thymosin alpha plays a unique role in balancing the pro and anti-inflammatory cytokine production through the involvement of distinct toll-like receptors acting on different dendritic cell subtypes. So there has been considerable research, and clinically, also the published studies have indicated that this can reduce the 28-day mortality from any cause in patients with clinically diagnosed sepsis by 9%, which is a very good number as far as the studies are concerned, and with a marginal p-value and decreased in hospital mortality. So this is something which is of immense significance for most of us, because thymosin alpha is available in India. Quite a few companies are marketing them, and we may try in our respective setups and see whether we get good result or not. Now, towards providing personalized therapy in sepsis, the research has been the provide randomized clinical trial has given some sepsis immune classification, and this sepsis immune classification identifies the ferritin levels and the HLA-DR. So if the ferritin level is less than 4420 nanograms per ml or HLA-DR is less than 5,000 per cells, this is the classification is the immune paralysis. If the ferritin level is more than 4420, then it is macrophage activation syndrome. And if the ferritin is less but the HLA is high, then it accounts for the intermediate state. And majority of the sepsis immune classification conforms with patients reportedly on immunoparalysis, and the least is the macrophage activation syndrome. So IL-1 receptor antagonist has to be used in patients with macrophage activation syndrome. So understanding the role of these biomarkers is also underway. We have understood quite a bit, but still we are left to understand with many more. So macrophage activation syndrome or macrophage activation like syndrome, MALS, and immune paralysis may be the basis of algorithm of personalized immunotherapy in patients with sepsis. And decreased MLA-THR is accepted as a marker to characterize this sepsis-induced immunosuppression. There has been studies with continuous intravenous IL-1 receptor antagonist infusion in different setup of patients, and particularly during COVID, we have seen that there were good number of trials. But all that can be said is that there is a need for further research to determine subgroups of COVID-19 patients. There was a need. And as much as now that we don't have COVID-19, in sepsis also it applies that we need to understand more the subgroups who might benefit by the timely administration of IL-1 receptor antagonist. Another new drug which has to be found to be good role in treatment of sepsis is the C1 esterase inhibitor, the alpha globulin, because this is controlling the first part of the classical complement pathway and is a natural inhibitor of complement. And it also inhibits the various proteases and a down regulator of inflammatory processes. Now, this has been used ever since its beginning as in angioedema, but in a dose of 25 units per kg infused over 1 to 2 minutes, it has been also be found to be useful or have some effect in sepsis. But we need more studies on the therapeutic endotypes before considering its use. Likewise, granulocyte macrophage, the GM-CSF, this has been also, the practice has been borrowed from oncology patients because GM-CSF is known to reactivate the immune defenses, activate the neutrophils, as well as assist in macrophage proliferation, differentiation, and phagocytic capacity. It may also restore the immune hemostasis in lungs with acute lung injury, post-COVID, etc., and promote lung repair mechanisms. And in vitro, GM-CSF promotes cell survival, proliferation, differentiation, etc. So this drug has been tried in sepsis also, and results have in models of bacterial, fungal, parasitic, and viral infections. It has been the absence of GM-CSF has been associated with increased mortality. And its administration, although had no effect on the prevention of ICU-acquired infection in sepsis immune suppression, but early termination of the study has been a limitation. And still we have insufficient data for which we need more confirmatory studies to draw conclusion on whether to use, number one, and in which patients to use. As for the which patients, of course, these are the immune paralysis patients in whom we have to consider their use, but further subclassification of those patients is necessary to understand. And as we know that novel ideas are always crazy until they're not. They emerge from our thinking about the problem. Like Cleopatra used to crush bugs to create the red color on her lips. And that's how the Kama Sutra describes lip coloring with beeswax and red. Like, but that gave origin to the lipstick. And today we have Revlon, Dyers, L'Oreal, etc. But they all follow the same lineage of generating through the novel ideas. So my take-home message is that sepsis is a dynamic disorder of dysregulated inflammatory and immune responses, where heterogeneity in patients is the rule, and therefore individualized immunotherapy has been the focus of research because individual immunological characteristics of patients is a promising therapeutic option. But it is still not clear that how we can establish an early warning system for sepsis and find effective biomarkers or immune checkpoints for this individual immunological characteristics. So a large part is still unsettled, but good work is going on. And necessarily, we have to combine advanced technologies like using omics and AI for prospective studies of personalized therapy. We had newer types, designs of trials, the umbrella trial, platform trial, which aids because they test multiple therapies and also adds omics-based biomarkers. So these are required in multiple clinical settings to improve our doubts about this. So thank you.